role of PET CT. Sorry, كده كويس. Okay. The diagnostic value of PET CT in gynecologic malignancies. And you know we have different imaging modalities in evaluation of gynecologic malignancies, including the ultrasound, Doppler, CT, MRI, and PET CT. The malignancies we'll deal with include the ovarian cancer, endometrial cancer, and cervical malignancy. As you all know that the main role of imaging is number one, to determine the extent of the disease at the presentation, also in proper staging, and to assess the therapeutic response, and to also to follow up for the possibility of disease recurrence. You all know the value of ultrasound in this domain, and also the CT is considered one of the rapid tools for evaluation. And according to the literature, the overall sensitivity is especially for the detection of peritoneal metastases in this range, and the sensitivity for smaller lesions will be much lesser. Then MRI is almost equal, and the only tool for metabolic activity or metabolic imaging is the PET CT. The basics for diagnosis of ovarian and the endometrial as well as cervical cancer include: the first, the ovarian carcinoma accounts for about 4% of cancers, and it is considered the fifth most common malignancy in women, and is considered also the common gynecologic malignancy leading to death. This is the average age of diagnosis, and about 75% of patients are seen in advanced stages. And there are many different types of ovarian carcinoma. Of course, you all know these types, and you know the basics for diagnosis of ovarian cancer, which includes the presence of a mainly cystic lesion with a considerable solid component, internal septations, and other signs of malignancy include the presence of metastatic lymph nodes, peritoneal deposits, and ascites. And this is the usual appearance of an ovarian carcinoma, showing its cystic component and a solid component or enhancing mular nodule. And bilaterality in ovarian cancer is well known, especially in the serous type of the cystadenocarcinoma. And this is an MRI, an ultrasound and Doppler examination for an ovarian cancer, showing a big cystic mass with very thick irregular internal septation and solid component, as well as internal vascularity. The staging of ovarian cancer is very simple. Stage 1 is tumor limited to the ovaries. Stage 2, extension to the pelvic soft tissues. Stage 3, implants beyond the pelvis. Stage 4, distant metastasis. And these are the routes of spread, the peritoneum and the hematogenous spread as well. And endometrial cancer is considered the fourth commonest cancer after the breast, lung, and colorectal cancer. And the common presentation is usually after menopause by vaginal bleeding. The role of ultrasound in diagnosis of endometrial cancer is relatively limited because the sonographic appearances are usually non-specific. And this is an example, and you see that the uterus is slightly enlarged, and there is a boloboid intrauterine mass with some vascularity on Doppler ultrasound. Also, the CT appearance of endometrial cancer is non-specific as well. The uterus is slightly enlarged, and it contains an abnormal soft tissue mass, which may invade the endometrium, as you know, the myometrium, as you know. Then by MRI, the endometrial carcinoma is a mass which is more bright than the myometrium in T2 and less bright than the endometrium. And of course, you know that in MRI we may use the triphasic study, and the literature says that in the delayed images the myometrium will be adequately enhanced, while the original tumor will be evacuated from the contrast. Then you got better appreciation of the degree of invasion of the myometrium. The stages of endometrial cancer, as you all know, this is stage 1A, less than 50% myometrial invasion, and B, more than 50%. Stage 2, invasion of the cervix. Stage 3, pelvic lymph nodes or para-aortic lymph nodes, and extension to the vagina, ovaries, and peritoneum without affection of the rectum or the renal bladder. Stage 4, distant metastasis and rectal or vesical involvement. Cervical cancer is considered the 8th most common malignancy in women, and then the 3rd most common post-menopausal gynecologic malignancy, and the age of presentation is around the 40 years old. And also the ultrasound has a limited role in diagnosis of the primary tumor. They will show a mass in the region of the cervix, and this is the staging of the cervical cancer. The cancer which is confined to the cervix, stage 1, extension beyond the cervix in the proximal part of the vagina, stage 2, distal part of the vagina and the parametria, stage 3, invasion of the colon and the renal bladder or distant metastasis, stage 4. And this is the appearance of cervical cancer by MRI, T2, sagittal and axial. You see a mass occupying the region of the cervix, and it has a little bit extension into the uterine body. And this is a stage 4B uterine cervical cancer with invasion of the pelvic side wall as well as retroperitoneal metastatic deposits. Then you know that PET-CT is a combination of PET and CT machines, and we use a certain isotope that is combined to a compound which is metabolically utilized in the body, and we select the appropriate isotope which has a reasonable half-life to facilitate the transportation of the material from the origin site to the site where it can be used. Then fluorine 18 with a half-life about 110 minutes is considered the most reasonable one, and is usually combined with glucose, which is commonly consumed by most of the cells in the body. Then the images of PET-CT are interpreted on the basis of the degree of uptake of the lesion by the injected isotope. And this degree of uptake can be subjectively measured or can be measured by the machine, and it's commonly agreed that the standard uptake value of around 2.5 will be suggestive of malignancy, and recent reports showed that the standard uptake value should be in the range of 3.2 or 3.6 for the confident diagnosis of malignancy. Then these images are presented everywhere, where you can see the difference between the pre-contrast CT scans, the post-contrast CT scans, and the PET-CT images, where you can appreciate the presence of metabolically active metastatic nodules in a patient with colorectal cancer. And if you look carefully in the pre-contrast and the post-contrast, you can hardly see the presence of these metastatic deposits. As I have mentioned, the interpretation of the images may be qualitative by vision, or quantitative by the machine. And the threshold for the standard uptake value is about 3.25, which can suggest the malignancy, and this is liable for many errors, as you know. Then what is the diagnostic value of PET-CT in gynecologic malignancies? This is in general to detect the primary site, to detect lymph node spread, to assess for distant metastatic disease, and the assessment of some of the difficult areas like the mediastinum and the supraclavicular region, and to assess the response of therapy or to predict the response of therapy, and this will be discussed. Then you follow the disease for the possibility of recurrence. For the patient to be prepared for PET-CT, the patient should fast for about 4 hours to lower the insulin in the and the blood sugar level, and to avoid muscular activity for false positive results, to drink some amount of water, and to avoid before the examination to empty the bladder, because it will mask many of the pelvic pathologies. Then you may give the patient oral contrast material, but do not give the patient intravenous contrast. In most of the times, the patient lies supine on the machine, and the scan should include from the skull base to the mid-thigh level. Also, you should interpret the patient for recent surgery, recent biopsy, and the history of chemo and radiotherapy, because these will affect the interpretation of the images. Common pitfalls in the PET-CT for gynecologic evaluation is the normal increased metabolic activity in the ovaries, for example, during ovulation, in the endometrium, during menses, for example, and also the increased uptake in the ureters, urinary bladder, bladder diverticuli, and the urinary diversion conduits, because the isotope is excreted by urine. And also you should be careful about the misregistration between the CT images and the PET images. And this is the uptake in the ureters, which is not, of course, seen because the absence of contrast material here. And you may have some of the limitations for PET-CT, including it is not reliably used to detect small lung deposits, small nodal deposits, and diffuse peritoneal carcinomatosis. And it may give false positive results in cases of acute inflammation, granulomatous disease, and some of the fibroids may show some increased uptake. And what is the value in the ovarian cancer in particular? And this is very important in patients with high or increasing tumor marker, CA125, and in the text that the conventional imaging did not show evidence of local disease recurrence. Then some of the literature says that PET-CT can be used as an initial and the only way for evaluation of ovarian cancer recurrence in the setting of increased tumor markers. Monitoring the therapeutic response is one of the values of PET-CT, but be careful that PET-CT is unlikely to be of benefit in the evaluation of indeterminate adnexal masses. If you don't know what is this tumor, this ovarian mass, PET-CT will not be of help. And then you can easily diagnose the primary tumor in the ovary by ultrasound, by CT, and by MRI, and this is not the major role for PET-CT. But what is very important is the diagnosis of spread, especially in the peritoneum. And these images are seen everywhere, where you can see the difference between PET-CT for detection of very small peritoneal implants, and the failure or these implants cannot be seen on the regular CT images. Also here you see a collection in the pelvis after surgery for ovarian cancer. Then PET-CT shows the difference, and this is what I have said about the misregistration. This is the urinary bladder, which contains the isotope, and the collection is not metabolically active. It is a post-operative collection. Also, post-operative scars will show increased uptake in PET-CT, and should be careful about this. And this CT scan of the abdomen in a patient with recurrent ovarian cancer and elevated tumor markers Then you can see some of the bowel loops are filled with contrast, but here you see a peritoneal implant, and they can be easily appreciated on PET CT. And this is the same in this CT. You see and something here, and it shows some uptake in the PET CT. In the context of elevated tumor markers should be considered. And also, this is a case of recurrent ovarian cancer with detection of internal mammary, para-aortic, left iliac, and the peritoneal. These are nodal implants, and this is peritoneal implant. For lymph node deposits, PET CT may result in false positive interpretation because of the inflammatory diseases affecting the nodes like sarcoid and TB. But in the setting of elevated tumor markers, PET CT is considered one of the sensitive tools for detection of metastatic disease of ovarian cancer in particular. Then you see here a case of recurrent ovarian cancer with a suspicious node here, and PET CT shows a metabolic activity in the node. And also, this is a case of recurrent ovarian cancer, and you see two sites, peritoneal deposit and lymph node deposit that has been confirmed after surgery. False positive results for PET CT can be seen in ovarian cystadenoma, some cases of teratoma, schwannoma, endometrioma, inflammatory processes, and also in healthy premenopausal women may show uptake in the ovaries and the endometrium, as I have mentioned. And this is a case of diverticulitis in the colon, and it showed significant increase uptake reaching about 7.1 SUV. And this is uptake in the scalene muscles after muscular activity, and this muscular activity should be avoided before the scan. And the literature says that PET CT alone seem to be particularly useful for the diagnosis of ovarian cancer recurrence when the tumor markers are increasing and the conventional imaging are inconclusive or negative. And this is a case of recurrent ovarian cancer with elevated tumor markers, and in this area you see an uptake which represents a serosal deposit, and this is the follow-up after chemotherapy showing the regression of this uptake. Then monitoring the therapeutic response, and this is under study, is not yet confirmed. And many times you want to know that the chemotherapy you are giving to the patient, is it effective or not? And then after one session or two sessions of chemotherapy, you may have a follow-up study by CT or by MR to see the response of the lesion. And the literature now says that you can use PET CT for this target, and you should have a basic pre-therapeutic PET CT. Then you may have another PET CT after the first cycle of chemotherapy. If there is a metabolic response, then there should be a decrease in the standard uptake value by 20%. And after the third cycle of chemotherapy, metabolic response equals a decrease by 55% in the standard uptake value. And this is an example of a PET scan of a case of recurrent ovarian cancer, and this is the follow-up 2 months after therapy, and you can see the good response to treatment. In endometrial cancer, PET CT has not been shown to be of value in the evaluation of endometrial masses and in the initial staging of the patient with endometrial cancer. And also the diagnostic value for lymph node metastasis is not better than MRI. Then PET CT may be of value in patients with advanced local disease in identification of extranodal metastasis, and maybe also of value in assessment of disease recurrence. In cases of cervical cancer, PET CT is considered of value in stages starting from 2B and above, or in early stage with a tumor size more than 4 centimeters, or in evaluation in the patients after the completion of therapy. And also it can be of value in detection of residual disease especially to consider the line of treatment. If the disease is confined to the primary site, then surgery may be possible. If the disease is has extended beyond the cervix, we may use chemotherapy or so. I mean that it can help in the treatment plan. In cases of cervical cancer, the value of PET-CT is doubtful in early stages, like stage 1B or less. And in detection of nodal metastasis, it is almost similar to MRI. In assessment of the treatment response in clinical trials, and I have said that this is under study. Then the sensitivity for PET-CT in detecting metastatic lesions, according to the literature, lesions less than 4 millimeter, the sensitivity is about 16%. Lesions between 5 and 9 millimeter, the sensitivity is about 66%. Lesions 10 millimeter or above, the sensitivity is about 93%. Thank you very much.